welcome. We're just going to give a few moments to let folks enter the meeting. Hope everyone's doing well. Per usual, feel free to use the chat to say hi, introduce yourself. Maybe you can share where you're coming from, beaming in from. All right, well, we will go ahead and get started. So my name is Brittany Saunier. I'm the Executive Director of the Partnership for Food Safety Education, and we're so pleased to have you all tuning in for today's presentation. It's a very timely presentation, so I hope you all enjoy it. It's my pleasure to introduce our speaker. So today our speaker is Dr. Elaine Scallan Walter. She is from the Colorado School of Public Health and the leading author of the data she's about to share today on this paper, the Foodborne Illness Acquired in the United States. So she'll be sharing the new estimates caused by 7 pathogens, and we'll be taking questions toward the end. So if you want to use the chat or the Q&A for questions, we recommend that. And I'll kick it over to you, Dr. Walter.
Great. Thank you so much, Brittany, and thanks to everybody for having me here. My pleasure to present some estimates that have just been published just this month in Emerging Infectious Diseases, looking at new estimates of the burden of foodborne illness acquired in the US for 7 major pathogens. So here's an outline of my presentation for today. I'm just going to go over some brief background and scope. I'm going to keep it short because I think this audience is very familiar with the need for such estimates. Talk about the methods, the estimates themselves. I am going to compare some of our findings to 2006, not for the purpose of evaluating trend, because we don't really do that with these snapshot assessments of the burden of foodborne illness, but rather to give you all some insights on how and why some of the numbers look different to what they did in 2006, and then just wrap up with some conclusions. So very briefly, why do we estimate the burden of foodborne illness? So I think most people here are very familiar with our public health surveillance and the data that provides, which is vital to understanding trends in foodborne illness. But we do recognize that surveillance data represents just the tip of the iceberg. In order for a person to be diagnosed and reported, they must seek care, submit a stool sample for testing. The laboratory needs a test for that pathogen, and it needs to be reported to public health. So we're okay with this just being the tip of the iceberg. Surveillance data still provides really vital information for looking at trends over time. But periodically it is helpful to have an assessment of the overall burden of these foodborne pathogens. I think also another piece that's important to recognize is that when we do surveillance, we're doing surveillance for the pathogen, and many of our foodborne pathogens are spread in other ways, including through water, contact with animals, person to person, etc. So these foodborne illness estimates give us an opportunity to look just exclusively at those illnesses we believe are transmitted through food. And we hope that these periodic assessments can help regulators, industry, public health practitioners, and others set goals and allocate resources, so where we need to focus our efforts to combat foodborne illness. So the most recent estimates were published in 2011 based on the year 2006. There were 2 papers published in EID at that time. One focused on 31 major pathogens and one focused on unspecified agents. And together, these papers gave us an estimate for the total number of foodborne illnesses that were domestically acquired in the United States. So since 2006, obviously many things have changed. There have been interventions put in place. There have been improvements in data sources. And I think for us in public health surveillance, one of the largest impacts has been the introduction of culture-independent diagnostics, or CIDTs. So the introduction of these new diagnostics has led to the recognition of more cases of some illnesses. There were some illnesses that were poorly detected by culture-based methods that are better detected using CIDTs. So that was a major disruption in surveillance, and something that we needed to include in these more current estimates. So when we began to work on these estimates, it was during the pandemic, and although our goal was to repeat and update the major pathogen paper, including all 31 pathogens that we had previously covered, we just deemed that not possible at that time. Many people in the different divisions at CDC that were subject matter experts and focused on these pathogens were detailed or involved in the COVID pandemic response, and we didn't want to delay anymore the updating of these estimates. So rather than try and do the whole 31, we decided to focus in on some of the most important pathogens identified in this 2011 paper. So what do we consider the most important? So, there's many different metrics you can use to assess that. We chose to look at illnesses, hospitalizations, and deaths and see which pathogens rose to the top across those different categories. So, for example, norovirus, Salmonella, C. perfringens were leading cause of illness, Salmonella leading cause of hospitalization and death, along with norovirus, Campylobacter, Toxo, Listeria. So we chose to focus on the 7 pathogens that through one or more of these metrics rose to the top. So these included Salmonella, norovirus, Campylobacter, Toxoplasma, E. coli L157, Listeria, and C. perfringens. By focusing on these pathogens, we not only hoped to kind of move forward in a more timely manner, but to also incorporate some of the new methods and data sources, including how to tackle the issue around CIDTs into this new estimates, this new methodology that we could then apply to other pathogens. And we're in the process of working on that at the moment and hope to have a more comprehensive paper in the near future. So the paper that has just been published in EID in April covers these 7 pathogens. With some small tweaks. Rather than just focusing on E. coli 0157, we also included non-0157. Our paper from 2011, at that time, there was more limited data on STEC non-0157. Before the introduction of CIDTs, that pathogen was harder to detect, or there's serogroups of E. coli were harder to detect, but we consider it to be an important pathogen. So we looked at all STEC rather than just 0157. We also took the liberty of looking at Salmonella not only overall, but to highlight the burden of some leading serotypes. And then for Listeria, we chose to look both at the burden of pregnancy and non-pregnancy associated listeriosis, which is often an important way with which we look at that data. So for our methods, we use a very similar approach to previous iterations, where we use the data available to us, often from surveillance, where we know the number of reported illnesses here at the top of the pyramid. In order for these illnesses to be diagnosed and reported, the person needs to seek care, submit a stool sample, the lab needs to test for that pathogen and identify that pathogen, and then report it to public health surveillance. So we begin with those reported cases with our goal of estimating the total number of domestically acquired illnesses at the bottom of the surveillance period. So our approach is to begin with these reported illnesses, adjust for underreporting if we think that is an issue, and then underdiagnosis. So adjust for the sensitivity of those diagnostic tests, the frequency with which labs test for that particular pathogen, the frequency which people are submit a stool sample for testing, and the frequency with which they seek medical care. And once we adjust for underreporting and underdiagnosis, we apply the fraction that is domestically acquired and foodborne. And I'll go into this in a little bit more detail. So these are the data sources that we use for our 7 priority pathogens. For Campylobacter, Salmonella, and STEC, we use data from the Foodborne Diseases Active Surveillance Network from 2017 to 19. We use data from the National Listeria Initiative for Listeria, outbreak data for C. perfringens, published studies for norovirus. The norovirus group at CDC has done a lot of work in the intervening years improving estimates of the burden of norovirus. So we took advantage of the work that they had done and included it here. And then for toxoplasma, we focused just on hospitalizations and deaths, which we were able to estimate using the national inpatient sample. So for this presentation, I'm mainly going to focus on, in a little bit more detail, on the methods used for Salmonella, Campylobacter, and STEC, which came from FoodNet. But though I'll briefly mention the other methods also. So for Campylobacter, Salmonella, and STEC, as I said, we use FoodNet data. We began with a number of cases reported to FoodNet surveillance. So because we wanted to go in a little bit more detail and look not just at Salmonella or STEC, but Salmonella serogroups and look at both O157 and non-O157, we had to do some work to partition those that where the serotype or serogroup was unknown or missing. So for Salmonella, we just randomly assigned those with an unknown serotype to one of the 6 serogroup types. For STEC, we took a little bit more of a nuanced approach because we know O157 is more severe than non-O157, is more likely to result in HUS, maybe more likely to be detected in outbreaks. So we used a random forest model to distribute those with a missing serogroup to either the O157 or the non-O157 groups based on those characteristics. Once we had the number of cases reported, we estimated the number of laboratory confirmed cases in the US because remember, FoodNet is a sentinel surveillance system. It only exists in 10 states across the US, representing about 15% of the US population. So we took the cases in FoodNet by year in sight and applied that to the US population to estimate the total number of lab confirmed cases in the US. We did assume no underreporting because FoodNet is an active surveillance system and has a very close relationship with those labs in the surveillance area and is doing auditing and ensuring that all cases are being reported to public health surveillance. Our next step after estimating the number of lab confirmed cases and making an adjustment for underreporting is to look at underdiagnosis. So for the lab piece, we're adjusting for test sensitivity and the frequency of laboratory testing. For this iteration, we had to consider both culture and CIDTs. For the purpose of this, we assumed that CIDTs were 100% sensitive. So we assumed that every case reported that was diagnosed with CIDTs to be a case and assumed that CIDTs were more sensitive than culture. So to determine the sensitivity of culture, we estimated the proportion of positive reflex cultures among all reflex cultures. And by reflex culture, I mean when a case was diagnosed with a CIDT and then sent to the lab for reflex culture, how many of those were positive? And we use that as a lower bound for that adjustment. For lab testing, we relied on data from FoodNet laboratory surveys, which reported the number of laboratories in the surveillance area that routinely tested either on-site or off-site for that pathogen. To adjust for medical care seeking and stool sample submission, we improved on the methods that we had used in previous iterations. Previously, we had grouped people into having mild or severe illness based on whether they had bloody diarrhea or not. But we know from other work that we've done that it's more than just bloody diarrhea or the severity of the symptoms that prompts people to seek care. We know that younger people, for example, children, are more likely to be brought to seek care when they have a diarrheal illness. So we wanted to incorporate those other factors in our underdiagnosis adjustment. So in this iteration, we estimated the probability of medical care seeking and stool sample submission for each laboratory confirmed case. And this was based on the probability of someone seeking care and submitting a stool sample based on data from the FoodNet population survey. So we looked at age group, sex, race, ethnicity, and the presence of fever or bloody diarrhea. So say, for example, a male child who was white and non-Hispanic and had fever and non-bloody diarrhea, they would have a unique probability of care seeking and stool sample submission, one that was different to somebody over 65 who was female and so on. Once we had an estimate of the total number of illnesses in the population, we focused on narrowing that to the number that were domestically acquired and foodborne. So to get the number of domestically acquired, we looked at the percentage of illnesses acquired outside of the US using, again, surveillance data from FoodNet, assuming the remaining proportion was considered domestically acquired. And then we looked to a structured expert judgment study to estimate the proportion foodborne. This again is a little bit of a shift from what we had done previously. Percent foodborne is one of the most challenging inputs for these estimates, and we had used a variety of different sources. These sources often differed by pathogen, including outbreak data, case control study data. But for this, we looked to this subject expert judgment, which considered a whole array of pathogens. And not only that, but different transmission routes. So they weren't just focused on what proportion is foodborne, but rather what proportion is foodborne, waterborne, animal contact, person to person, so on, which I think is a really important piece, because if you ask somebody to estimate foodborne without bounding that estimate with these other transmission routes, you often end up with a higher proportion than maybe should be the case. And you'll see that in using the expert judgment study, our percent proportion is lower, I think, for most pathogens. Just briefly, for hospitalizations and deaths, we looked at the proportion of laboratory confirmed cases that were hospitalized or died, again by year and FoodNet site, and applied those to the number of laboratory confirmed cases. And then we adjusted for underdiagnosis. For those of you who are familiar with previous iterations, we adjusted for underdiagnosis for hospitalizations by doubling the number. This was something that came from previous iterations, including the Mead study in 1999. Always a little bit unsatisfying using a number that is not based on good evidence. So we did some work in the intervening period between the 2011 paper and this paper to try and come up with some more data-driven estimates of the number of people who are hospitalized and submit a stool sample, which we did, and the references for the papers are at the bottom of this slide. So that was satisfying to have a more data-driven approach to adjust for stool sample submission for hospitalized cases, and paired that with the frequency of lab testing and lab test sensitivity to adjust for underdiagnosis. So very briefly for Listeria, we used the Listeria initiative. This is a shift. We had used FoodNet previously, but in the intervening years, Listeria initiative has become a very strong surveillance system. So, and given the severity of listeriosis, we feel like there's a good level of reporting to this surveillance system. So we chose to go with that national system. We did look at both pregnancy and non-pregnancy associated listeriosis. And also importantly, in surveillance, while mother and child are counted as a single case, for burden, for the number of illnesses, we wanted to count the mother and infant separately. And we did that if listeria was isolated from that person, or if the mother or infant of somebody with an invasive infection had symptoms. For C. perfringens, really the only data we have available to us is from the Foodborne Disease Outbreak Surveillance System. We included 10 years because there's quite a lot of variability by year in terms of the number of outbreaks or the number of cases associated with those outbreaks. We adjusted for underreporting by comparing pathogens that had data in both FoodNet and in the Foodborne Disease Outbreak Surveillance System to see how frequently cases are part of an outbreak. And then for underdiagnosis multiplier, we relied again on the overall Salmonella underdiagnosis multiplier, just given the lack of data available specific to C. perfringens. For norovirus, as I mentioned, the norovirus group at CDC has done a lot of work in trying to better estimate the burden of norovirus. So we use data from two studies. One included active surveillance data from Kaiser Permanente in the Northwest. Another used market scan data, along with hospitalization data from the National Inpatient Sample and death data from multiple cause of mortality data sets. And those data were used to inform our norovirus estimates. For toxoplasmosis, we decided just to focus on hospitalizations and deaths. That's really why toxoplasmosis was listed among the most important pathogens, because it was a driver of hospitalizations and deaths. We did not include illnesses. It's just challenging with toxo. So many infected persons are asymptomatic, and it's really hard to know what proportion of those experience illness, most of which is mild. So we just focused on the hospitalizations and deaths. Just finally, all of these many inputs were based on empirical data to define distributions. Each of them has uncertainty, and the uncertainty in our final estimates is the cumulative effect of uncertainty in each of these multiple inputs. So we used 10,000 iterations to obtain empirical distributions that corresponded to Bayesian posterior distributions. So every estimate has a mean and then a 90% credible interval. So I'll share some results. So overall, these 6 of the 7 where we looked at illnesses contributed to 9.9 million domestically acquired foodborne illnesses out of a total of approximately 38 million total illnesses due to all transmission routes. Together with toxoplasma, this resulted in just over 53,000 hospitalizations and 931 deaths. So I'm just going to briefly show you our ranking, and then I do have another slide that shows a ranking for illnesses, hospitalizations, and deaths compared to our previous estimates, so you can see how things have shifted. So for illnesses, norovirus was by far the leading cause of domestically acquired foodborne illness, followed by Campylobacter and Salmonella. And one of the things that you will notice is Campylobacter becoming higher in the rankings, really across the board for illnesses, hospitalizations, and deaths. And much of that, I think, is attributable to the use of CIDTs and the increased detection of Campylobacter. And again, we'll look at some of those data too. For hospitalizations, with this new data available from CDC, norovirus became the #1 cause of hospitalizations, followed by Campylobacter, Salmonella, and STEC. And then for deaths, Salmonella was the leading cause, followed by Campylobacter, norovirus, and Listeria. So this graph just looks at illnesses, hospitalizations, and deaths. It shows the point estimate and the credibility interval for pathogen estimates from 2006 and 2019. 2006 is shown in red, 2019 is kind of shown in the teal blue. And really the only thing I want you to take away from this is that in most instances, there is no significant difference between the estimates from 2006 and the current estimates from 2019. The only place where you do see a significant change is for toxoplasma, where there is a significant decrease in the estimated number of illnesses, hospitalizations, and deaths, or hospitalizations and deaths, I should say. So here's just a comparison of 2019 to 16. And again, I'll preface all of these slides with, we don't want to be using these periodic assessments to look at trends over time. Rather, I just want to show you how rankings have changed and also give you a little bit of insight into how some of the inputs have changed over time. But compared to 2006, we can see that like norovirus continued to be the leading cause, though as I mentioned, Campylobacter did rise in the rankings for illnesses, as it did for hospitalizations. So in 2006, Salmonella was the leading cause of hospitalizations, followed by norovirus. Now we see norovirus and Campylobacter ranked slightly higher than Salmonella. And for deaths in 2006, Salmonella was followed by Toxoplasma, Listeria, norovirus, and Campi. Now we have Salmonella remaining as the leading cause, but followed by Campylobacter, norovirus, Listeria, and STEC, and Toxoplasma has declined, or there's a smaller number of estimated deaths due to Toxoplasma. So kind of broadly, what is driving some of these estimates? I think especially for Salmonella and Campylobacter and STEC, it's being driven by an increase in the number of laboratory confirmed cases, and some of this can be attributed to the widespread adoption of CIDTs, which has led to increased detection of these pathogens. We have seen real declines in the incidence of some illnesses, specifically Toxoplasma, which has resulted in now a lower estimate in 2019 compared to 2006. We've also, I believe, improved our approach to adjusting for underdiagnosis. We're now being just much more nuanced in how we look at the probability of care seeking and stool sample submission, taking into account not just symptoms of bloody diarrhea, but also demographic information. And that has led to an increase in the underdiagnosis multiplier for some pathogens. And then I think another major change was the new estimated percent foodborne in the expert judgment versus what we had used previously, though that typically resulted in a slightly lower proportion foodborne. So I know we're just coming up on the half hour, and I really do want to leave time for questions. But I just thought I'd give you just a quick kind of peek under the bonnet of the inputs to show kind of what was driving some of the differences we're seeing in the estimates from 2006 and now. I'll go through them briefly, and then during the discussion portion, if anybody wants me to bring these up again or talk about them in more detail, I certainly can. I have some slides, one for each pathogen, with the illnesses in blue, hospitalizations in green, and the deaths in yellow. And it just shows just some of the inputs to give you some insight into what may be driving some of the differences in 2006 versus 2009. So you can see for Campylobacter, the number of lab confirmed cases increased dramatically, again, likely due to the increase in CIDTs and increased detection of that pathogen. Our multiplier also increased with our new method of incorporating age and other factors into our multiplier, and you'll see this across the board. Some other things like travel remained fairly stable for Campylobacter and some other pathogens, while you'll see another trend that using this expert judgment, the proportion foodborne declined. So here for Campylobacter, we attributed 80% to foodborne transmission in 2006 and just 57% based on the expert judgment. So combination of all these factors, we do see quite a large increase in the estimate of domestically acquired Campylobacter illnesses. Data also suggests an increase in the hospitalization rate. So this, coupled with the increase in cases, led to the increase that we saw in the number of hospitalizations due to Campylobacter and the deaths due to Campylobacter. I will note, for all our work that we did trying to have a more data-driven estimate to adjust for underdiagnosis for hospitalizations and deaths, we ended up with a number that is quite similar to the 2 that we had assumed in previous iterations. So here for Campylobacter, it's 1.7. So just very briefly for some of the other pathogens, Salmonella, we saw a slight an increase, not as dramatic as for Campylobacter in the lab confirmed cases. Also for the underdiagnosis multiplier, you'll see a range here for the travel related, because we looked at each of the 6 individual serotypes and then summed for the overall burden, but roughly it's staying the same as what we had previously, though the proportion foodborne is lower, and I think quite rightly lower when we account for these different transmission routes. So higher than in 2006. For XTEC 0157, we're also seeing an increase again with CIDTs. Also in the multiplier, see a slight increase in the proportion travel related and a slight decrease in the proportion foodborne. The proportion hospitalized and died are roughly the same, slight increase for proportion died, but our multiplier for hospitalizations and deaths is slightly lower than the 2 that we had used previously. For non-0157, this is the first time we've had really good surveillance data to work on. Previously, we had this huge multiplier for non-0157 because we were trying to account for the fact that we didn't have a good diagnostic test for these serotypes, serogroups for STEC. Now we do, and that has led to a dramatic tenfold increase in the number of laboratory confirmed cases. So these are not really directly comparable, because this was trying to account for the data that we didn't have in 2006. But as much as we tried to account for lab testing, we obviously didn't account sufficiently, because with these data now, we see a much higher estimate than we had previously thought for non-0157. For listeriosis, we see just very slightly smaller numbers than we had previously. In the paper, I don't include it here, we do delineate between pregnancy and non-pregnancy associated cases. For C. perfringens, the estimate is slightly lower than we had seen in 2006. And for toxoplasma, a dramatically lower estimate of hospitalizations and deaths. But this is something that we do see in other sources of data for toxoplasma, and is largely likely attributable to the better control of HIV and AIDS, which was a major risk factor for that disease. So some limitations. Our data come from a variety of different sources, which the quality and representativeness varies. We try to take account of that in our uncertainty estimates, but that certainly exists and should be taken into account when looking at the uncertainty intervals. We're still underestimating illnesses caused by some pathogens. Just to acknowledge that, we didn't look at illnesses caused by toxoplasmosis. We know that there is gastroenteritis associated with listeria, which is not often reported to public health surveillance, but is evidenced in some outbreaks. And then while we tried, when we did estimate the number of fetal deaths associated with listeriosis, no doubt this is an underestimate of that. And also there are long-term complications and sequelae. So just concluding, these 6 pathogens are estimated to cause 9.9 million domestically acquired foodborne illnesses, resulting in 53,000 hospitalizations and over 900 deaths. I think our estimates are meant to be a piece of the puzzle, and we hope they can inform policy and food safety interventions. I think it's important that they offer a platform and are paired with other data to be able to take these illnesses and partition them to specific foods, or inform economic estimates, or form a basis for looking at disease sequelae, which are also another important piece. So I will end there, and I would be very pleased to take any questions that people have.
Thank you. And yes, if you have questions, please feel free to use the Q&A box or the chat box. We do already have a question in there for us. This person writes, what is your opinion regarding the limited information or lack of surveillance on foodborne diseases and major pathogens in Mexico? So that's a big one.
Yeah, and I also think maybe a little bit outside my scope is very much on what we're doing domestically here in the US. I'm not that familiar with the surveillance or lack of in Mexico. I know we are very fortunate in the US to have some strong surveillance systems for these pathogens.
Yes,
But
thank you.
yeah, I'm sorry, I don't.
That's okay. That's what we do here, right? We ask questions and we figure it out. So you touched on this a little bit, but my question for you would be, and just briefly here at the end, how are you hoping this data could be used? And you did touch on a little bit, but maybe adding some more light there.
Yeah, well, I think so IFSAC, or the Intergovernmental Food Safety Analytics Group, I think has been a really successful partnership between CDC, FDA, and USDA, and in giving us what I believe to be is the next step of, taking these illness estimates and partitioning them to certain foods, giving us the additional specificity we need to really target interventions. So, so I think that is one direction, and I hope the work of IFSAC continues and they incorporate these new estimates into some of their work they're doing. The Economic Research Service also published recently looking at the economic burden of foodborne disease. I think that can be a really powerful advocacy tool, and so hoping that some of these data will be incorporated into those estimates. And as I mentioned, I think disease sequelae is one area where we do lack information on the impact of complications and sequelae from foodborne disease in the US. I think that's a really important piece. I think that has a very large, substantial impact. So these can be a foundation for improving some of those estimates, but I think on the whole, we need to improve our ability to estimate what those long-term sequelae are.
Yeah, thank you. And yeah, I definitely see a lot of potential for this data to be used for targeted approaches. As you mentioned, I think that could be really valuable. We had a couple of questions come through here. One person wants to know, do you have any data around children and senior populations susceptibility, any outliers around these populations?
Yeah, I mean, that's always really appealing to focus and look at those populations. And following on from the 2011 paper, we did produce 2 papers that looked for select pathogens at the burden in older people and in children under 5. It can be challenging for some pathogens to have that level of detailed data, not only about the number of cases in those specific age groups, which by and large is available, but how does healthcare seeking differ, or like how does the proportion of foodborne differ? Because even for a pathogen like salmonella, we have a huge rate of infant salmonellosis in the US. I don't think those kids are getting that from like eating undercooked poultry. So there are other exposure rates and different exposure rates, I think, for some age groups, particularly younger children. So I think it is really appealing to try and be more nuanced and look at the burden in those specific age group. It's something that we would like to do. Having all the inputs can be challenging when looking at those specific inputs, but I encourage whoever asked the question to look at the papers that we have produced so far. And you know, I think for certain pathogens like Salmonella, for instance, you know, there may be enough information to try and move forward, and it's definitely on the list of things that we would like to do with these estimates.
Thank you. We do have one more question here. And then I think maybe some of this might crossover from your previous response, but this is specific to norovirus. So for norovirus, foodborne hospitalizations and deaths, can you elaborate more on susceptibility factors and setting or food consumed?
I'm not sure I'm going to be able to give the best answer, just norovirus not being my, you know, the pathogen that I focus on. And as I said, we relied largely on what the norovirus group does. I mean, I think one thing I will say for norovirus is, you know, it is the most common cause of domestically acquired foodborne illness. So while I think, you know, that norovirus, like the rate of hospitalizations and death is not that high, there's just so much norovirus that's what pushes norovirus up the top in terms of hospitalizations and deaths. So the rate is not that high, but there's just so much of it. And I believe in the work that the norovirus group at CDC have done. You know, much of that is among elderly or older people who contract norovirus. So certainly happy to direct whoever asked that question towards some of the good work that has been done at the norovirus group at CDC that have looked at that in more detail.
Thank you. And just a shameless plug here. We also did recently a webinar on norovirus. So a deep dive there. So which is a great segue for wrapping this up, because we have that presentation, previous presentation. We'll have this presentation also on our events page at fightback.org. So you can catch the recording again. And then we'll also have a version of the slide decks available as well. So we
And
appreciate.
I will just say, you know, just kind of in response to the question of, you know, about different age groups, and like we have been trying to be responsive, because I mean, the reason we're doing this is to help you all and regulators and others who use this data to advocate, prioritize, and so forth. You know, so in this iteration, like our regulatory partners really wanted to look at serogroup for Salmonella, right? So we provided that. So we would love to hear from you all, like what is useful. Like, you know, if age groups is something that would be really important for you to let us know, and for what pathogens, and, you know, so we can incorporate that into future planning. Because I mean, this data is for you all to use. So knowing how it can be most useful, or how it can be broken up into different estimates, would be helpful to know.
Absolutely. Yes. So please let them know. All right. Well, Dr. Scallan Walter, thank you so much for your time and sharing this important work with us today, and beyond, really. I guess that would conclude today's event. Are there any parting words that you'd like to offer?
It's just thank you for having me here. And yes, like, please feel free to reach out if you want any more information on these estimates, or, and especially would love to hear about priorities for future work.
Yeah. Fantastic. Well, thank you all and have a great day. Thank you. Bye.